morning, everyone. Myself, Dr. Deepak Kumar, and I'm working at East Central Railway Hospital at Dhanbad in India. I'm presenting this paper, the joystick technique, which is an easy, reliable, safe, and cost-effective technique in closed reduction and percutaneous fixation of supracondylar fracture of humerus in children. And I'm presenting this as a co-author. Coming to the introduction of the topic, uh, the supracondylar fracture of the distal humerus is almost 16% of all pediatric fractures, and it constitutes around 60% of the fractures occurring in the pediatric age group at and around elbow. Most commonly, it is found to be extension type, and very rarely it is found to be a flexion type. But the problem is the significant morbidity is resulted by this fracture. And in 12 to 20% patients, it usually results into the Bronstock deformity, that is malleable. And in rare conditions and worse scenarios, neurovascular injuries and compartment syndromes are also there. When we approach to a case, we must take the detailed history, clinical examination, and we have to look for the radiological evaluation. In the history, we should look for the swelling, bruising, and puckering sign, which reflects the engagement of the uh, proximal fragment into the soft tissue, which usually do not allow the fracture to get reduced. And if there is S-shaped deformity, it gives an idea about there is complete fracture, which is of type 3 or type 4 as per modified Gartland classification, in which the distal pike of the proximal fragment and olecranon tip forms the S shape. In clinical evaluation, we should go for the neurovascular examination very carefully. And in 10 to 20% of displaced fracture patients, there usually we found that there is some kind of vascular compromise, either in the form of some vascular some kind of vascular compression or tear. And we should always look for the detailed examination of associated nerve injuries like median nerve and interosseous nerve, radial nerve, and ulnar nerve. We should always look for this nerve carefully. And if there is any kind of clinical sign which is pertaining to this deficit, we must record it for the medical legal purpose. Coming to the radiological assessment, we should take the radiological films in two different planes, preferably at 90° to each other. And in AP view, we should look for the Bowman's angle, which gives us an idea about the coronal plane deformity or displacement. In lateral view, we have to look for different landmarks like anterior humeral line, coronoid line, and fat pad signs. If there is any deformity which is resulted by the rotational component of the fragments, we get a fishtail shine. And based on these radiological examination, these fractures are classified into various types. Like classically, it was classified by Gartland in three different types: type 1, type 2, and type 3, in which the type 1 was hardly displaced or non-displaced fracture, and anterior humeral line was passing through the center of the capitulum. In further, in type 2, there was minimal displacement, and the posterior periosteum was intact, which leads to the passing of anterior humeral line anterior to the center of capitulum. While type 3 is the most severe one, in which the fragments are completely displaced. Further modifications in this classification system has been developed by different authors, and the type 2 fracture was further classified in two different groups, type 2A and type 2B. In type 2A, there was the intact posterior hinge, but there was no any further rotational component as well for the distal fragment or pulsing fragment. While in type 2B, there was rotation of the distal fragment. In type 3, there was further subclassification into two groups, in which type 3A was posteromedial displacement type and type 3B was posterolateral displacement type. And the type 4 was further added, in which there was complete disruption of these hinges and lead to circumferential and unstable fracture fragment. And it was intraoperative discovery. When we try to look for the rotational component, we should look for the lateral view, in which when we look for the lateral view of the elbow joint or distal humerus, it should be cylindrical throughout its course. But when there is any rotation, this cylindrical configuration of the distal humerus is lost and leading to fishtail sign. And further, there was many studies which was clearly showing that what was the factors responsible for these rotation. Actually, uh, in continuation with the displacement and rotation of the distal fragment, there was rotation of the proximal fragments as well, which is caused by the deltoid muscle, supraspinatus muscle, and infraspinatus muscle, which act in uh, which was acting together and causes the external rotation. And further, the complete loss of periosteum hinge was also responsible for this rotation to took place. There was a study conducted by Wang et al. And in his study, he clearly hypothesized that when we try to reduce this fracture, we have uh, periosteal hinge, which is also augmented, which was also responsible for the augmentation in reduction by the pronation or supination of the fracture fragment. When we talk about the posteromedial displacement, it was the medial periosteal hinge which was responsible for the correction of the deformity when we pronate the forearm. While in the similar fashion, when the displacement was posterolateral, it was the lateral periosteum which was responsible for the helping, which was responsible for helping in the reduction by supinating the forearm. So, because of these uh, background in our mind, we have conducted a study, and in this study, we have found that the conventional method of traction, flexion at elbow, and either pronation or supination, depending upon the fracture fragment displacement, uh, we were not able to reduce it correctly. So, we have, with this background, we have some ideas that we may land up in uh, losing the fracture fragment. We may require some open method to reduce the fracture. And there was some cases in which when we apply the fixation of the fracture by the K-wire, from the medial side, we have many studies have shown that there is ulnar entrapment in almost 7 to 12% of patients. And if there is medial combination, then ultimately leads to gunstock deformity. Wingfield et al. In 2015 has published his study and has uh, uh, suggested that there are many ways of the fracture reduction by the open method. But It was the posterior and lateral approaches which were highly uh, uh, cosmetically unsatisfactory result. In while the anterior approach was the method in which we developed relatively lesser and better cosmetic results. So we have conducted this study, which was a prospective study from June 2017 to 2021, and the cases were 24, and we have followed these patients for 6 months to even, and the outcome was assessed using Flynn criteria. And the inclusion criteria was all the fractures were type 3 or type 4, 3 to 12 years, and within the 5 days of injury. Initially, uh, we go through the pre-op evaluation using initial clinical assessment. We uh, put we have given some analgesia and tried to reduce it closely so that the higher deformity gets becomes the lesser one, and we applied stent test. In this process, we have looked for the X-rays, serial X-ray before manipulation and reduction and after reduction. In the meantime, we get some blood investigation for the preoperative period. There was a study conducted by Zhao and Zhang in China, and in that study, they have advised that the crossed pinning fixation was more at risk for atherogenic ulnar nerve injury. So we have studies in with these uh, new technique in which we have applied the K wire as joystick to reduce the fracture factor. We have used this Kirschner wire of size 2 to 2.5 millimeter from lateral to medial direction in bicortical fashion at the center of cylindrical control of the socket fingers, around 5 to 7 centimeters proximal to the fracture line. And after putting that joystick, when we internally rotate that joystick, the fracture was reduced and the amount of internal rotation was more than 45 degrees. So when we look for the initial radiological X-ray in the CR, there was facial sign. After applying the joystick and internally rotating it, that facial sign was get corrected and the fracture was fixed. And for the fixation, we used multiple K-wires from lateral to medial direction and from posterior to anterior direction for the better purchase and divergent fashion. There was the video in which we are showing that when we are internally rotating the K wire as joystick, that cylindrical contour of the distal end of humerus was better managed. And for applying the K wire, the, the joint line was marked, the distal end of humerus was marked at the tip of olecranon, and the fracture point was marked, and the cylindrical contour was also marked. And that K wire was passed from lateral to medial direction at the center of the circumferential contour, cylindrical contour of the proximal humerus. And in that way, the K wire was fixed. And by applying this K wire, when we internally rotating the joystick, that cylindrical contour was re-established on the lateral. In this way, the amount of force required was so large that it leads to the bending of the K wire, which was used as joystick. These are some take-wise X-rays, and we have followed this patient for the post-op period, and the uh, fixed the lateral K wire, which were used for fixation of the fracture, was removed after 3 weeks, and the elbow movement was started after 4 weeks of fracture fixation, and the radiological evaluation were taken at 6 weeks, 3 months, and 6 months, and 1 year post-operatively. There were 14 male and 10 female patients with average age of 6.5, 6.5 years, and the average surgical time was 38 minutes, and no fracture was reduced by the open method. The mean age was again which was around 6.5 years, and the mean duration was around 38 minutes, and mean radiological fracture union time was 6.9 weeks. Most commonly, the fracture which was we were dealing with was posteromedially displaced, and though there were no loss of reduction at the 3 months of post-operative period. During the COVID-19 pandemic, we lost 3 cases, and at the beginning, 2 cases were reported with radial nerve neuropraxia, which was resolved in the due course of time. And 1 patient got superficial surgical site infection and was managed by serial risk. There were a case in which we developed iatrogenic fracture of shaft of humerus because of the eccentric placement of the joystick, but it was not leading to any disturbances in the fracture union time at the supracondylar region, and no ulnar nerve entrapment was noticed. In the Flynn's criteria, 13 out of 24 patients had excellent outcome, and 8 were having good outcome. These are my cases. This was the earlier preoperative X-ray in the March 2020, and which was later followed up and the lateral view in August 2021 by the same technique. The loss of range of motion was between 0 to 5 degrees only, and there was no any coronal plane deformity as such. This is the post-operative radiograph at 9 months of follow-up. Another case in which the fracture was grade 4 type, and it was fixed by the same method using multiple K-wires from lateral to medial direction. It was the clinical evaluation at the final follow-up, and radiologically the fracture was healed quite nicely, but we have to make sure that we should be cautious while placing that joystick. When we are placing it in the center, it is very good, but when we placing it eccentrically, it will lead into the unicortical breach. On further rotation, it may get fractured, and such case was happened, and we had managed it in the form by the intramedullary K-wire fixation in antegrade fashion, and the same 2.5 millimeter K-wire was used with the closed method only. This is the clinical photographs of the same patient had shaft of humerus fracture during the operative period and is doing fine. So my take-home message is, when we are trying to pronate or supinate the forearm for reducing the fracture, and it is not enough, then we should apply a joystick, which reduces the surgical time, surgical stress, and C-arm exposure, and no fracture need to open. And when the fracture is accurately reduced and fixed adequately, then the Flynn's criteria automatically comes in the satisfactory functional range. So the conventional method of reduction, we are augmented with the help of joystick. We have not changed that conventional method, but we have used another method to help the fracture reduction. It was a single center study and with very limited number of patients. So we cannot say that our study or our technique is superior to the other. These are my references.